Welcome back. Before we move forward, here's a quick recap of what we covered in part 1. The RAS cascade starts with renin, leads to angiotensin II, and causes vasoconstriction and aldosterone release. ACE inhibitors block the ACE enzyme and raise bradykinin, which is why they cause that dry cough in about 10 to 15% of patients. ARBs block the AT1 receptor directly. Same clinical benefit, but no cough. Now, let us build on that and talk about when and why we use these drugs, what to watch out for, and how to counsel your patients. Clinical indications. Both ACEI and ARBs are first-line treatments for hypertension, particularly in patients who also have diabetes or chronic kidney disease. In heart failure with reduced ejection fraction, these drugs reduce mortality and hospitalizations. They reduce the cardiac workload and prevent the harmful remodeling caused by angiotensin II. In diabetic nephropathy and chronic kidney disease with proteinuria, RAAS blockade is the standard of care. By reducing intraglomerular pressure and blocking aldosterone, these drugs slow the progression of kidney damage. Post-myocardial infarction, ACE inhibitors, especially ramipril, are started early to prevent adverse cardiac remodeling and reduce the risk of recurrent events. Adverse effects and contraindications. Let us be clear on the side effects. For ACEI, dry cough is the most common, affecting up to 15% of patients. It is harmless but very bothersome. That is your signal to switch to an ARB. Angioedema is rare but potentially life-threatening. It presents as sudden swelling of the lips, face, tongue, or throat. If your patient reports this, stop the drug immediately and consider it a contraindication for life. Both ACEI and ARBs can cause hyperkalemia, especially in patients with kidney disease or those taking potassium-sparing diuretics like spironolactone. Monitor potassium closely. Both classes cause a rise in serum creatinine in the first few weeks. A rise of less than 30% is acceptable and expected. If creatinine jumps more than that, you need to reassess. The big absolute contraindications for both classes. Pregnancy. These drugs are teratogenic, causing fetal kidney abnormalities and death. They are category D and X. Any woman of childbearing age on these drugs must be counseled about contraception. The second contraindication is bilateral renal artery stenosis, where these drugs can precipitate acute kidney failure. Now for counseling, because knowing the drug is only half the job. 10 patients to take it at the same time every day. Missing one dose is not a disaster, but they should never double up to make up for a missed one. Warn them about first dose hypotension. They may feel dizzy, especially after that first dose. Tell them to sit on the edge of the bed for a minute before standing up. If they develop a dry cough on an ACEI, they should tell their prescriber. Do not just stop the medication on their own, because there is a simple fix, switching to an ARB. If they ever notice swelling of the lips, face, or tongue, that is a medical emergency. Go to the ER immediately. Remind them to avoid high potassium foods in excess. Avoid regular NSAID use, since ibuprofen and naproxen blunt the drug's effect and strain the kidneys. And to get blood tests for potassium and creatinine 1 to 2 weeks after starting or after any dose change. And that is a wrap on ACE inhibitors and ARBs. You now understand the RAAS pathway, how both drug classes interrupt it at different points, what they are used for, what to watch out for, and how to counsel your patients. Both classes are cornerstone RAAS therapy. They are essentially equivalent for blood pressure and organ protection. Choose an ARB when your patient cannot tolerate the ACEI cough. If this video helped you, please like it and subscribe to R times Russia Pharma Basics. I will see you in the next episode.